All right, let's talk about tracking infection recovery. We're going to dive into how we can move past some of the old school and honestly, sometimes misleading signs we've all been taught to rely on. We'll explore how to use modern biomarkers to get a way clearer picture of what's really going on with our patients.
So, picture this. It's a scenario we've all been in, right? You're on day 3 of antibiotics, the patient's fever is finally gone, but you get the morning labs back, and their white count is still stubbornly high. So, what's your next move? Are they actually getting better? Is the antibiotic failing, or are we missing something completely? It's this exact kind of ambiguity that shows us why we need better, sharper tools to guide our decisions.
So here's our game plan. First, we'll quickly touch on the limits of our old tools. Then, we'll get into the good stuff, your new biomarker toolkit, focusing on CRP and PCT. We'll look at how to use them in that critical first 72 hours. After that, we'll learn how to decode the difference between real recovery and a brewing complication, talk about some common pitfalls, and then we'll wrap it all up with a new clinical mantra you can take to the wards.
Okay, so let's jump right in. We have to start with the basics, right? For decades, we've leaned really heavily on things like temperature and white blood cell counts. But it's high time we had an honest conversation about their limitations.
You see, the real problem here is that things like fever and a high white count, well, they're just general alarms. They're not specific to a bacterial infection at all. I like to think of them as the check engine light in a car. Sure, it tells you something is wrong, but it doesn't tell you what or where the problem is.
And here are just a few of the things that can really muddy the waters. You could have an elderly patient with a raging infection who never mounts a fever, or a post-op patient whose white count is through the roof just from the stress of surgery or a dose of steroids. And that can make you think an infection is getting worse when it's not. Relying on these markers alone, it can send you down the completely wrong path, either stopping antibiotics way too soon or, more often, continuing them for way too long. Okay, so this brings us to the stars of our show today. C-reactive protein, or CRP, and procalcitonin, PCT. You should think of these as much more sophisticated storytellers of the body's immune response. They give us the details the old tools just can't. First up, we've got CRP. Now, CRP is a really sensitive marker of inflammation, but it's not very specific. Pretty much any big inflammatory event, whether it's an infection, major trauma, or surgery, is going to make it rise. The key thing to notice here, though, is its kinetics. It has a relatively long half-life of about 19 hours. And what that means is that its decline is slow and steady, which actually makes it a fantastic signal for tracking the overall resolution of inflammation over several days.
And then we have procalcitonin, PCT. Now this one is our specialist. Its production gets kicked into high gears specifically by bacterial toxins. But here's the cool part. It's actively suppressed during most viral infections. And that specificity, that is its superpower. It makes PCT an absolutely invaluable tool for antibiotic stewardship. So the most important thing to get is that they have different jobs. CRP is your broad narrator. It tells you about the overall arc of the inflammation. Is the fire getting bigger or is it getting smaller? PCT, on the other hand, is the specific narrator. It tells you if that fire is likely bacterial, and crucially, it tells you when it's probably safe to stop pouring antibiotics on it. They aren't competing with each other. They're the perfect team. Okay, so let's get practical. How do we actually use this stuff? Well, that first 72 hours of treatment, that's really where these biomarkers can have the biggest, most immediate impact on your decisions. So here's how it usually plays out. On day 0, you start your antibiotics based on clinical suspicion, and you get your baseline labs. Super important. By day 2, the CRP is probably peaking, but if your antibiotics are working, you should already start to see that PCT trending down. This whole sequence sets you up perfectly for what we call the antibiotic timeout at that 72-hour mark.
This timeout is a fundamental principle of good antibiotic stewardship. It's a built-in moment to just pause and ask, are we doing the right thing here? So you combine your clinical assessment and your culture data with the objective trends from your biomarkers. It's this third step, looking at the trends, that gives you the confidence to make a really solid, decisive move in step 4. And when we're talking about PCT, this is the number you need to remember. A drop of 80% or more from its peak value, that is a very, very strong signal that the bacterial infection is under control. And it tells you it's probably safe to think about stopping antibiotics, as long as the patient is also getting better clinically. Now, besides that 80% drop, there are also some absolute numbers that have been proven out in big trials. For a lot of respiratory infections, a PCT under 0.25 is a common stopping point. For more severe stuff like sepsis, that threshold is a bit higher, maybe around zero point 0.5. But, and you knew there was a but, right? This is the most important part. These are guides, they are not gospel. You never, ever treat a number. You always treat the patient sitting right there in front of you.
So we've seen how to use these for stop rules, but now let's get a little more advanced and look at how their patterns, their trajectories over several days, can tell a much richer, more detailed story about what's really happening. Now, while the trend is what matters most, the absolute value of CRP can give you a quick sense of the scale of the problem. A level over 10, that's when you start thinking about significant systemic inflammation. And when you see a CRP over 50, well, in about 90% of those cases, an acute bacterial infection is driving the train. But this right here is where the real power of CRP comes in, interpreting the pattern over time. A steady decline, whether it's fast or slow, that's exactly what you want to see. That's reassuring. But a non-response where the CRP just stays flat and stubbornly high, that's your clue that something is wrong. Maybe your antibiotics aren't cutting it, or maybe you haven't achieved source control. But the most alarming pattern by far is the biphasic response. It starts to fall, you get a little bit of false hope, and then bam, it shoots right back up. That is a massive red flag.
And here is your take-home action point. If you see one of those two scary patterns, the non-response or the biphasic one, this is not the time to wait and see. This is the time to act. It's time to re-image, to repeat cultures. You need to go on an aggressive hunt for the reason therapy is failing. Think about things like a hidden abscess or a brand new secondary infection. Of course, as we all know, medicine is never quite as clean as the textbooks. So let's quickly cover a few common situations where you need to add a little bit of extra nuance to how you read these numbers. Okay, 3 big ones. First, post-op patients. You should expect their CRP to spike from the surgery itself. What you're really watching for is that dreaded biphasic pattern. A second rise after post-op day 2 or 3 is hugely suspicious for a complication like a leak or an abscess. Second, patients with renal failure. Their baseline PCT can be high, so don't get fixated on those absolute cutoffs. For them, that 80% fall from peak is going to be your most reliable guide. And finally, your immunosuppressed patients. They're the ones who often can't give you those classic signs like fever. So for them, these biomarker trends become even more essential for tracking their real progress.
Look, this is so important, it's worth saying again. At the end of the day, these are just numbers. Yes, they are incredibly powerful tools that add crucial objective data to your assessment, but they are absolutely not a substitute for good clinical judgment and actually putting your hands on and examining your patient.
So we've covered a lot. What is the one single idea that you should take with you to your very next shift, to your next set of rounds?
Here it is. Burn this into your brain. This is your new mantra. Recovery is defined by the patient's organs getting better. Is their oxygen requirement going down? Is their creatinine improving? Are they hemodynamically stable? That is recovery. The biomarkers are there to support and confirm that clinical picture you're seeing. We are officially moving away from chasing fevers and white blood cell counts as our primary goal.
And that's really the challenge I want to leave you with. On your very next patient with a serious infection, when you get to that 48 or 72-hour mark, I want you to think about this framework. Look at the trends, combine them with your clinical picture, and just see how it can help you make a more confident, a more data-driven, and ultimately a better decision for your patient.